So amyloidosis is a disorder where misfolded proteins form long, non-branching fibrils that deposit in various organs throughout the body. Two common forms of amyloid that affect the heart are light chain, which is caused by immunoglobulins, which are produced by the bone marrow, and the second is transthyretin, which is produced by the liver, and both are underdiagnosed and highly fatal diseases. So in order to diagnose amyloidosis, one has to conduct a biopsy, or they can also test serum and urine levels as well. And then with cardiac amyloidosis, in order to diagnose it, it is typically suspected in echocardiography. And this is seen in the right thick ventricle over here, as well as in MRI. You'll see similar features in it as well. But with echocardiography and also MRI, it's not specific for amyloid, and it cannot distinguish between the AL or the ATTR type of amyloidosis. So in order to do that, you have to do imaging of technetium-99m pyrophosphate scans, and this is specific for the ATTR version of cardiac amyloidosis. So in a study by Gilmore et al. In 2016, it was a large multi-centered study that showed that PYP amyloidosis was about 100% specific to the diagnosis of ATTR cardiac amyloidosis. And so cardiac amyloidosis is a type of restrictive heart failure, and it has a very high mortality. The American Heart Association publishes annual statistics, and it shows that the prevalence of heart failure is rising throughout the country, as seen through the increase in the graph. And this is measured through ICD billing codes. And in this study in particular, it followed the prevalence from 1997 to 2014. However, amyloid in this study, since it was just focusing on heart failure in general, it did not focus on amyloidosis, cardiac amyloidosis. And so the objective of our study was to perform a retrospective pilot study to evaluate the utility of ICD-based definition to cardiac amyloidosis. So this chart right here, this flow chart, shows how we diagnose cardiac amyloidosis using either ICD codes or a reference diagnosis. So we obtained an RPDR that had about 6,383 subjects, of which I was able to evaluate 139 patients over the summer. So I got through about 2% of the of the data. And so these are the codes that were used to diagnose amyloidosis and heart failure. So this is what was seen on the right side of the chart, of the flow chart. And then my role in the study was to serve as the reference diagnosis. And I did this by reviewing EPIC charts. And I diagnosed amyloidosis based on proof of a biopsy that proved that there was amyloidosis, or through a strongly suggestive PYP scan. And then from that cohort that had the amyloidosis, those meeting the Framingham criteria of heart failure were then identified as cardiac amyloidosis. So the study variables were normally distributed and reported as mean plus or minus standard deviation, or as percentages when appropriate. So this table here shows the distribution of ICD codes for amyloidosis. The unspecified codes were reported at about 50% over here. And then the codes specific for cardiac amyloidosis, which were 85.81 for AL and 85.82 for ATTR, were about 22.2% when combined together. So this stacked bar graph shows in dark red the percentage of patients confirmed with amyloidosis in regards to the reference standard. So we saw that about 50% of the patients met the criteria for being diagnosed with amyloidosis. However, when we considered only the specific codes, the two that were in bold in the previous table, we saw that the yield increased to 88%. And overall conventional metrics such as specificity and sensitivity could not be measured reliably because our subjects were selected based off of a code for amyloidosis. However, when we looked at the diagnosis of cardiac amyloidosis versus amyloidosis in the previous slide, our concordance was about 59%. And these results are rather lower than what we had expected, so further analysis needs to be done with these cardiac amyloidosis codes. So in these next two slides, I will show a comparison of characteristics between those who had amyloidosis, or who had amyloid present, and those who had it absent. So baseline characteristics were similar between patients who had amyloid and those who didn't. But we saw that there were more men in the amyloid group. And this was also seen with a history of carpal tunnel syndrome, where those with amyloid present had a higher comorbidity of carpal tunnel syndrome. And then usage of heart failure drugs like loop diuretics, spironolactone, and anticoagulants were also used more by patients with amyloidosis. So overall, our study had several limitations, one of them being the sample size. As stated before, I only was able to get through 139 charts. And then we also only evaluated first encounters of amyloidosis. So that meant that if patients or subjects were diagnosed with amyloidosis outside of the partner system, we were not able to see that because we did not have access to that. And the last limitation that we saw was that we were at the cusp of a transition. So the ICD-10 codes for cardiac amyloidosis, the AL and the ATTR, were introduced in 2017. And so my cohort was 2018 to 2019 in terms of the subjects that I studied. So because of that, the cusp of the transition, we imagine that that played a role in being a limitation. And then overall, in this pilot study, we evaluated an ICD-based definition for the diagnosis of cardiac amyloidosis. And a reference diagnosis by chart review identified amyloidosis in only 48% of the patients. However, when we looked at the small subset that used the more specific ICD-10 codes for AL and ATTR, the yield of that increased to 88%. Hence, the use of new specific ICD codes for AL and ATTR should be introduced into the healthcare system. We hope in the future to complete the analysis of all 6,383 patients as well. So thank you to the STARS program and Dr. Gravala's lab as well.
Thank you very much, Samantha. This paper is open for discussion. Questions?
I wanted to, I know what it is, but I wanted you to clarify what are the Framingham parameters for heart failure, which you mentioned. You have a slide on that?
Yeah.
That's great.
Oh, it's not showing. Hold on. Let me unhide it. That's not what I meant. So the Framingham criteria was established during the Roosevelt period because the president had heart failure and she took a stroke. So what the Framingham criteria is that it's a 20-year cohort study in which it was in Framingham, Boston, and so it really evaluated what were baseline characteristics of what they were seeing in patients with heart failure, because back then heart failure was not defined. And so with the Framingham criteria, in order to diagnose somebody with heart failure, you would either look at the major criteria, so you would need one major criteria and one minor criteria, or you would need two minor criteria in order to diagnose somebody with that. And with this project in specific, you would have to read encounters from the doctors and look for the symptoms, unless they were cardiologists and they would let you know. But for the most part, yeah, it was going through patient notes and finding the major and minor criteria.
And it is still ongoing.
Yes, this is an ongoing study.
Yeah.
I think they're phase 3 or 4 now.
Yeah, there's tons of papers on that.
Yeah.
Really interesting.
Can you talk more about what specific things in the patient charts you were looking for to make the diagnoses that you did?
In terms of the Framingham?
Or for this study with the cardiac amyloidosis?
Okay, so what I looked for first was the PYP scan in their imaging folder. And so if I was able to find that, then I would read to see what grade it was at. And if it was at grade 3 or 4, which suggested that it was highly specific for ATTR, then that would be a diagnosis of amyloidosis.
Okay.
And if they didn't have that, then I would look for a biopsy, a pathology report on amyloid to see. It didn't matter where the amyloid was. It could be in your gums or in your kidney, just any diagnosis of amyloid at that point. And then, in terms of the heart failure, I would look at the heart, the notes, the encounters, emergency room notes, cardiology notes, even neurology notes, all over. And then also from there, I also had to do demographic work, such as male, female. Does this person have atrial fibrillation? Does this person have carpal tunnel syndrome, bicep tendon rupture, all that, so. They were there. So I looked at them in regards to the notes, but not in regards to like how to actually like the imaging themselves, just because I'm not qualified to read them in that sense. Yeah, no, but I would read if you know if the ventricle is like hypertrophic, it's like the percentages, like oh this is ejection fraction is not normal. So I would read into that, but like the notes are there. I did not access them.
Samantha, great presentation and great work, actually great job. I'm not sure if all of you realize, but she had to review almost close to 200 charts, I think of which 139 were included here, and go through all the notes, biopsy records and everything else. So her study is really the very first piece in our much larger project. And once we get the database built, we will be looking at echocardiograms, presumably using some form of machine learning approach. So that's one of the things that would come out of this eventually. So thank you.
Thank you for that clarification. Other questions? No, question for me is kind of what will be the applicability of your findings? The fact that you've now increased the specificity from 48% up to 88%.
Well, it wasn't really specificity, it's yield at this point, but I think that it's important to really recognize that amyloidosis is a much more prevalent disease than what it is. So since I'm going back to school in the South, cardiac amyloidosis is prevalent in African Americans, in more African Americans. So in a paper by Alexander, there was a suggestion that like perhaps people in the South are being underdiagnosed for cardiac amyloidosis. So I think that this study, like examining the cusp of the new ICD-10 codes, can bring into light that perhaps that doctors or physicians need to be like considering that patients with heart failure are actually having cardiac amyloidosis at this point.
Excellent. And I think similarly, the upside of the ICD-10 code is that it means that a provider actually thought about this diagnosis and they're actually billing for it.
Yeah.
But if we're missing a large number of amyloid because we're kind of treating it as hypertensive heart disease and LVH from hypertension, then we may miss it.
Yeah.
So would you consider kind of looking at the machine learning of echocardiograms and patterns with comorbid conditions to see whether or not the yield could be different?
Yeah, I think that it's like important to look at the comorbidity. So for instance, like Korsakoff-Tunnel syndrome is like one of the definite, comorbidities with cardiac amyloidosis, such as like bicep tendon rupture. So looking at things like that would really, bring about the prevalence of cardiac amyloidosis. I feel that at this time, a lot of physicians, just because of the way that differential diagnosis and Bayesian probability works, you're not gonna consider cardiac amyloidosis as your primary diagnosis because it's so rare. But is it really rare, or is it that we're just not looking at the incidence and prevalence enough, or is it not being coded correctly? And at this point now, it's also important to realize that cardiac amyloidosis does have a new drug on the market. So, prevention and diagnosis of it early could really, decrease the mortality of the disease.
Perfect. And given the fact that tafamidis is now on the market for treating TTR amyloid, as you move forward, would you be interested in kind of breaking out the TTR amyloid from the AL and other amyloid, in terms of trying to understand how precise the diagnosis is?
I think that there are current studies, and Dr. Ravala's had that focus on that. So she's got a MICA study that focuses on the AL version of cardiac amyloidosis. And then tafamidis only addresses the ATTR version of it. So I think that doing research on both is important because the AL is unfortunately more fatal than the ATTR. Well, they're both fatal, but with AL you only have about 6 months to a year. Meanwhile, with ATTR, you have about 2 years. So definitely doing more research into both types would be, within our best interest in the medical community.
Perfect. Other questions? Excellent. Thank you very much.